combined IASES, SESI, and IAS virtual semi-annual meeting. Both Mandeep and I are super excited for the program, whether it's late night or early morning, from all of you and your participation. Just a few housekeeping reminders as we get started. There's 3 sections. We'll keep them at 30 minutes and try to stay on time to value everyone's overall attention, but also schedules, whether it's late night in America or in India, early morning to get you to work. Specifically, we'll have 3 different sections. A few housekeeping things are, if you have any questions in the Ortho Live TV, we want you to submit them in the chat room, and they will be shared with all the faculty and the moderators to be able to address. In addition, we also will have any chats in our Zoom link as well. The chat will be, the questions can be submitted that way. And we will have discussions and any time for questions after each of the 30-minute panels. Otherwise, we're really thrilled and excited to have a diverse faculty, and I think Ram's going to get us started.
Thank you. Thank you, Vani and Mandeep and the whole IASES team to have this continuing for the 4th year. And I'm excited to participate here. The first session would be on proximal humeral fracture. What's new? What's the best? How to optimize outcome? And thank you, my panel, Dr. Anand Murthi from Baltimore, Maryland, USA, Dr. Deepthi Nandan Reddy, Hyderabad, and Dr. Shirish Pathak from Pune. So let us start the cases. First patient, a 55-year-old gentleman, right-handed lawyer. He fell while walking his dog, fall on outstretched hand, and sustained injury to his right shoulder. So that's his X-rays. Anand?
Well, first, sometimes it's good if a lawyer falls and breaks his shoulder, but we'll keep that separate. He has, from these 2 views, he has a displaced greater tuberosity fracture. His neck fracture looks in good alignment from the Y view. Looks like his retroversion's okay. If he is active, I would probably address the greater tuberosity fracture. As I feel if it heals that way, he'd probably lose some motion and function.
Would you be requesting further imaging, Nandan?
Yes, definitely. I would like to get some more imaging just to see the degree of displacement of the greater tuberosity. And there is a valgus impaction. So there is a degree of head impaction laterally. That's the reason why the GT looks higher.
Yeah. And you could, Shirish, are you here? Any comments before we proceed? I think he's yet to join. Okay. I think if you look at that plain X-ray, there is a fracture line along the neck as well, right?
Yeah.
Right.
So very important to have 2 orthogonal views, but in fracture scenario, sometimes it's not possible. So if you suspect any neck fracture or interarticular fracture, it is better to have a CT scan. And that's your CT scan picture. Nandan, you want to go?
I love 3D. Sorry, I just say I love the 3D. The 3D CAT scan is the best way to go.
Yeah.
Yeah, so it's more than what we could see on an X-ray, obviously. And there is the degree of, injury to the lesser tuberosity too, in addition to the greater tuberosity. So I think you need to get this into a better position and stabilize it.
So we have this situation. 55-year-old is actually a 4-part fracture. A head is impacted, undisplaced lesser tuberosity with the moderately displaced greater tuberosity. And what will be your choice of treatment? Nandan?
I think for this percutaneous screw fixation, once you correct the head tilt with the greater tuberosity coming down, should be a good option. But a mini open type of percutaneous fixation can be done with screws.
Basically, accept the head impaction, but just improve the greater tuberosity position.
No, you can elevate the head too.
Head too and fix it with percutaneous. Yeah, okay. Anand, your comments?
Open reduction, internal fixation through a delto pec with plate and screws.
Okay. So that was done. Is done elsewhere. These are the immediate post-op X-rays. Comments? Anand?
I think, the key is getting that calcar screw really low to make sure your head doesn't fall. I can ask you some technical aspects. If you put a lot of sutures in the cuff and the greater and the subscap, I think is important. But the alignment looks good.
And this is 1 month post-operative.
Beautiful.
Beautiful. Okay. And what do you think about that lateral view? Fine. Do you get normally a axillary lateral view, or
Yeah, usually a true AP, a lateral and an axillary, at least at after 2 weeks where they're a little bit more comfortable. Yeah. I can see the lesser looks like pretty good alignment as well. Okay. There's some callus, looks like there's some callus posterior.
Yes. And this is 2 months post-operative. The patient was surgeon, unable to lift the arm up, and severe pain.
Yeah, the GT escape is pretty, I'm seeing a lot of these, or not a lot of them, at least more commonly, because I think one thing I've noticed when I went back and revised these is that the top 2 screws, when you put too many of the top 2 screws, it tends to break the intact metaphysis, which is there just below the attachment of the rotator cuff, and that weakens that spot. And once you start mobilizing these patients, the rotator cuff gets pulled off. So that's one of the problems we noticed, although your reduction is good and everything else, but if you don't put sutures on the rotator cuff.
Yeah, I think as Anand was mentioning, the rotator cuff sutures and indirect reduction is the key, because what you don't see on the X-ray is the sutures.
Right.
So
and it's key. I mean, if you don't, and if you don't do that, you're really your plate ends up being a neutralization plate if you really do good suture fixation or tapes or whatever you like to use. But it's really tenuous if you don't use the sutures or tapes, because these tuberosities and fracture fragments can pull through the screw fixation, especially any locking screw.
So this is the situation when he came to me, 2 months post-operative. This is the true AP. If you can see that there is a 30-degree tilt, so you could see the glenoid plane, and the greater tuberosity is clearly escaped, and the patient has a pseudo-paralysis with pain and stiffness also. Active flexion abduction is only 30-40 degrees. So that you could see the greater tuberosity fragment. And that is a CT scan we have done to check it. You could see clearly the greater tuberosity escape, but the remaining head and the shaft fracture is healed very well. So, and we also noticed the significant deltoid atrophy for him. So we did a nerve conduction test, which shows some evidence of neurogenic changes, both denervation and reinnervation. So it could be possibly some added axillary nerve neuropraxia or injury. So that is his current problems: 55-year-old, dominant hand, 2 months post-ORIF, GT escape, stiff shoulder, slightly prominent plate, not very long screws, and probably axillary nerve lesion as well. And how do you take it from here?
That's a simple case to start.
Yes.
When I see these greater tuberosity fractures that are either missed or this happens late, it is really hard to get the greater tuberosity back and healed and functional. I think it's only been 2 months, so there's still a chance. Yeah. Sometimes later you'll see the greater heal to the glenoid, and it's really impossible other than reverse or something like that. So I think I would try to repair the greater again, knowing that he also has this nerve injury. I would do a release at the same time to get his passive motion. I would brace him in external rotation, some type of external rotation brace to take the tension off. Yeah. But I'm worried about this one.
Okay. Nandan?
Yeah, I think I would go ahead and because the head is healed, that's one good thing here. And as Anand had just mentioned, that the injury was only 2 months old. I think the cuff will function well, and you have a reasonably sized chunk of bone there. I would go in with I would not probably go in through the same incision. I'll go in through a deltoid split incision.
Deltoid split, yeah,
And
yeah.
I'll get the tuberosity, take out the top two screws, tuck the tuberosity fragment into the plate and between the plate and the head, and suture the cuff down onto the plate.
I think I have covered pretty everything because it's something which we see here with missed or escaped graded tuberosity. I went through deltopetal, but not through the medial scar because so medial that scar was, so I released it.
Yeah.
If you look at it, as soon as we open the approach, you could see the articular head and the tuberosity is posteriorly retracted, posterior-superiorly, and I couldn't see much of sutures. So this is the key message I want to give. I think what you don't see on the X-ray is the sutures, which do the key importance in fixation. So again, I started, again, as Anand said, mobilization is difficult at 2 months. So we have to be patient and get first traction sutures, retrieve a bit more and more sutures, because you cannot, you have to handle the tuberosity now with the utmost gentle care. And as I dissected, I saw it is actually two pieces. One supra pieces as well as one the posterior GT. So actually the entire GT has escaped. That's why he had a poor function. So once we do that, you can see the sutures now all the way through from greater and also additional lesser. And I counseled him about removing the plate because sometimes the plate is in the way, and the revision of plating as well as reverse shoulder. So I counsel for every possible option because we cannot guarantee result with this approach. But I was able to get a good result. So then once you do that, I remove the top two screws because, as Nandan said, that is a problem in the GT fractures. And we need also space to put the bone graft. So I put the synthetic bone graft here. So take calcium substitute, and that is your fixation now. As you see the X-ray, the GT is brought back under the plate. The plate is prominent, but you can let it be like that until the fracture heals, and that's a rotation. So it's again post-operative. Whenever I fix GT, I put this neutral rotation brace. Want to avoid internal rotation because that will be the distraction.
I love it.
Yeah, thank you. And
A couple questions and comments in the chat. What about the
Yes.
axillary nerve? Does that not scare you?
And
And then what if you couldn't reduce the GT fracture? What would you do?
Yeah, number one, axillary nerve, I wasn't planning to go in and dig it out because on the EMG showed some partial reinnervation potential. So I probably think that it might be because of the approach or neuropraxia or recovering injury. Didn't want to go further. Second, I have counseled him that if the GT is not coming, if you are not able to fix it satisfactory, I would remove the plate and do a reverse. Because no other option is good. Hemi will not work without a good GT. So that's the outcome, 2 months post-operative, and he has recovered around 75% of the movement. And interestingly, most importantly, you could look at the external rotation. He's got the power in the external rotation with the GT, and the fracture is healed. Subsequently, after 1 year, I removed the plate as well because it was slightly impinging. So just to summarize the finding after this case, the complications after plating, there are some biological complications like avian infection, fracture. We don't have any control over it, but there are complications like long screw or missed dislocation or implant inappropriateness. This could be improved. So I just summarized because the topic is what's new, what's best, how to optimize outcome. I summarize these salient features. Number one, we are putting a locking plate. So you have to get sutures and you have to reduce the fracture first. That is a prime important. Second, do not use the plate as a reduction tool only except for calcar reduction, because I often see the plate is sitting out. So sometimes you don't have good control. Third, as Anand said, calcar screw is gives the construct stability, and also not so long screws. This is not a hip to chase the tip apex distance. And also do a dynamic screening. Most common complication is long screw. I do a dynamic screening, see it, make sure that it is not there. Any screw, if you're feeling doubtful, remove it. Welcome, Shirish. We'll
Yes.
you for the next case. So remember, the fixed angle plate, the level of the plate dictate your screw. So you have to get the plate correct level. Okay. So, but there are advances. what we have variable angle. Here, you can change the angle of the plating, angle of the screw. So the plate can be at a position and you can angle the screw in a slightly different direction as much it allows. So that gives an added advantage like this. So the greater tuberosity area doesn't need to get disturbed. Like the other fixed angle plate, you get the plate level correct, but you have to put the screws there and you damage the existing GT bone that can also weaken the construct. And we have a carbon reinforced peak plate, which I have good experience. There are a lot of advantages. It is still variable angle and biologically inert. And most important is radiolucent. It is bone-like elasticity. And the important bit radiolucent is that you can check the reduction intraoperative and also monitor healing process. Augmentation is buzzword you're going to hear in the next two talks as well. So you can augment with the anterior small plate for the lesser tuberosity fragment. You can augment with a synthetic graft as we have done here, or in a non-union setup, we can do a fibular graft. Sorry, this is a fibular graft. We do only for non-union, not for primary. And our Dr. Jitendra Maheshwari has done only fibular fixation, also a possible option. And this also, I see that screw tip cement augmentation to augment the head. Any experience with this, Anand? Because we don't have this system still available in India.
For cement?
Yeah.
I haven't used I've used some different types of calcium phosphate type of, that's fluid and then it hardens.
Yes, not through the cannulated
not
screw.
through the screw. I agree with you on just having a lot of screws that are not that long but spread out, like a bouquet, so it really controls.
Thank you. Now we have Anand Murthy's.
Can I just ask one question?
Yes, Karthik.
Why that small graft, sir? What was the need for that small graft? Do you always have to put that the bone graft substitute there, or what was the exact purpose of it?
In the revision case which I did?
Yes,
to support the void, because the GT fragment you brought in back, there is a void, metaphyseal void. You have to fill it.
It actually looked quite nice on the X-ray post-op, but I would not have thought about grafting that.
Yes, because basically the greater tuberosity has to touch the metaphyseal bone and heal. If it is not touching, it is constantly under pull. The sutures and fixation you cannot.
So you filled that wall.
When you do revision scenario, you better to do augment with the graft.
One other thing I've noticed when you're using a plate as your buttress for getting your tuberosity down with your rotator cuff is that your tendency is to pull the tuberosity down.
Yes.
Because there is always, it depends on the plate position. If your plate position changes, the pull of your greater tuberosity also changes when you're using sutures on the plate. So if you're finding that you're pushing it down, you put an augment inside, will actually get the tuberosity back up, and there is a good compression between the bone fragment and your native bone, so the healing potential is better.
Yes, Shirish, say something?
I just want to add, not for this particular case, but wherever possible, in addition to sutures, I try to put a screw outside the plate, fixing GT to the head, and
separately
transform my results like anything.
Yes.
The healing happens so well that abduction and external rotation is not a problem.
Yeah, provided the quality is good.
The quality of tuberosity is good.
Yes.
What size screw, Shirish, do you use for that extra GT?
Cannulated cancellous screw.
Okay.
Ram sir, just one question before. Think about the axillary nerve. Suppose what is a good time to explore the axillary nerve? And second question is, if you're not able to reduce the GT or the GT is completely resorbed, so you said you go for a reverse. The axillary nerve injury and a reverse. So how do we go about it?
See, clinically, it's got evidence of axillary nerve injury, but it is recovering.
If it is not, what is
if it is not, it's a different ball game. Okay, you have to treat as though it is a complete axillary nerve injury. Then your reconstruction will also likely to fail. And we have to think in terms of removing the plate and exploring the nerve and possible transfer, etc. But he was recovering, so I was hopeful. Okay. So moving to this, I think this case example Dr. Anand wanted to show is that, can you talk us through, Anand?
Yeah, so let's go back one picture. So these are just some other augments or options, for intramedullary fixation, if you have a lot of comminution or an older patient. Next slide. So this is using a distal ulna, which I've used for many years. The advantage over traditional fibula is that the distal ulna has a flare that you can utilize to keep the head from falling into varus. So you can see they come in various sizes. You can cut it short if you'd like to. This is the proximal shaft. You can see was pretty comminuted. Next slide. And this is the reduction we got. We brought the head over without any fixation. We did fluoroscopy and it was incredibly stable. And then we, if you go to the next slide, we did a traditional plating with variable angle, and she did well. So distal ulna is another option for intramedullary fixation. It's readily available in most graft banks as well as the fibula, and allows you some potentially better rotational control.
Okay, thank you. So we'll move into the case 2 by Anand, 71-year-old female, physiologically young patient, dominant hand, sleep on ice, transferred in and with severe pain. That's your picture. These are the images. Shirish, what you would like to do?
Of course, I would like to investigate if CT scan is possible, because it's a...
That's a CT.
Yeah, so it's a comminuted proximal humerus fracture. But yes, good news is that head is intact. I was suspecting a head split fracture over there, actually.
Yeah.
So head is good, and there's a big splinter which is anterior. Yeah, so I think it's a comminuted fracture. Only thing which is different is it is extending to the shaft. So
your fixation with the method of choice.
I would go for open reduction, internal fixation with a long phyllos plate.
Long plate.
But I'll try to be
straight lateral, Shirish? Straight, just one plate? Straight lateral?
So basically, how do you address
my plan would be to reduce 4 into 3, 3 into 2 fragments. So I would like to fix first the shaft fragment, the anterior splinter with maybe 2 anterior posterior screws, interfragmentary screws, and get it as a 1 unit. And then probably same steps. I need to tag tuberosities, get everything back, and minimal soft tissue dissection, and put a long plate, at least 6 cortices distally, if possible 1 in the middle, and 3 or 4 screws proximally. And I'll just protect for 3 weeks, go slow on rehab, and should do well.
And what will you do with the deltoid insertion, Shirish?
No, I'll just carefully erase it and put it back. Should not be a problem.
That is something to be remembered. Anterior deltoid could be elevated subperiosteally to place the plate, long plate, and then you can suture the deltoid back again to the plate holes or the bone. Nandan, what is your choice?
I think this is a case which I would ideally prefer a nail, intermediate nail, because one, you can get, yes, good sutures on the tuberosity first to start with, get your head reduced properly, get all the fragments reduced, and then drop a nail, a straight nail.
And how would you address that lateral flare, the part that's abducted with the nail? How would you get that reduced?
No, that will reduce. That will reduce. Once you reduce the fracture, open reduction done. Go deltopectoral, and you go and you reduce the fracture, and then you put the nail from the top. So it's not that difficult actually. Actually, you'll get a better stability with that, and you use the sutures to the screw holes.
Can you take us through, Anand?
Sure. So lots of options. This is an option I've used now for these long extended metadiaphyseal fractures, double plating, especially when there's a lot of comminution, and if there's poor bone, older patient. You can see we've put the plate on the front. You can take down some pectoralis. So you can use a periarticular plate on the side. You don't have to detach much deltoid laterally, and then you stabilize the long shaft component with a long plate in the front. So it decreases your deltoid disruption. It's very rigid, so you can start moving a little bit earlier. Not that you have to move all these fractures early. And this is your result. So this is what I've used for the big, long, kind of metadiaphyseal type of fractures.
What
do you think, Nandan? Way too much?
Yes. Can I make a comment on this? Because see, there's 2 things. One, you see that the head is actually gone into a bit of varus. And that control is very difficult when you have a proximal metaphyseal comminution. And if you put a nail into the articular surface of the head, you can control that better. One. Secondly, that degree of soft tissue dissection is not required. One thing I was curious to note that are you gone to complete stainless steel implants in US, or are you still using titanium?
Well, that depends on what contracts you have at your hospital. But we right now we're using stainless steel, this company, but there's titanium as well. I haven't used the carbon fiber yet, so that's intriguing.
As interesting, I saw your presentation. So we had been doing a lot of these in UK, and we published our about 15 or 20 cases, a long phyllos plate, as Shirish Pathak was telling, elevating the anterior deltoid, fixing with only one plate. And that serves the purpose most of the time. Maybe I accept that in a very resistant non-union, I use the additional plate, but sometimes I use a long lateral plate and a short anterior plate over the fracture side. So moving to the next case, a 22-year-old with a snowboarding injury, displaced to two-part fracture, a quick poll, Shirish.
I'm a plater, but I'm sure Nandan will say nailing, because for me it's the ideal one, but I'll go plating.
Does he only have one answer for every case?
Different angle, right?
I think it's divided 50-50. Basically, I would go for plating because in my hands, I don't want to. My concern is the rotator cuff disturbance in a very young patient. So, deltopetal approach, open a short plate and secure. That's my favorite. But again, Nandan, nailing, correct? Anybody
Yes,
do
but
this? No.
I think nail is a good option.
Conservative? Would anyone wait for a little while, see if it reduces better? Sling.
If he was more than, 22 is too young and it's a high energy injury, the chance of your soft tissue damage around that is higher. So I think if by good reduction and getting it anatomical is better.
Take us through your rationale and
this is the a lot of doing this is a nailing, and a lot of this is setting it up with your fluoroscopy on the bed properly, so you get all these good views, and you can actually do percutaneous through the rotator interval, so you're not having to violate the rotator cuff. Next slide. So we're getting a good view. We're getting our starting point. Next slide. You can do it with an articulated arm holder. So you can almost do it with one person. So you're getting right in that bicipital groove tubercle area. So you can see it's pretty percutaneous. It's a woman. So, the deltoid pec, no matter what you say, it does leave a long scar. And then it has, at least this nail has an arm for guided interlocking screws. Next slide. And this is 5 weeks. Pretty rigid fixation, 6 months, back snowboarding. Cuff function is very good. So I think, especially for me, I'm traditional plater, but I think for these two parts, especially with good bone, that for me, a nail is a good option in these cases. How'd I do, Nandan, on that one? How'd I do? A plus?
Yeah. I think the current generation of nail allow us to lock from front to back side as well. So I think they're much more better than the previous generation nail. So that's my
100%. 100%.
Can I just pick on one thing? Because we go through the rotator cuff and this are much more medial. I think your entry was really medial. And how did you manage to get away from the acromion when you're doing that? And
so if you flex the arm forward, if you extend it and you come just in front of the AC joint, you can get it out of the way.
Okay, and you don't repair the rotator cuff later?
No.
Ram, I have a question.
Yes, Shirish.
Sometimes, not particular this case, when there is medial comminution, when you fix with plate and you find intra-op that in few views, you do see some varus. It's not 135, it's probably 130, 125. So what is your limit of acceptance? Where you will say that, no, I wouldn't accept even a 5 degree or 2 degree of varus, because few of cases where I accepted and still they went on healing well. So is there any official limit where you should stop and where you cannot?
There is no.
You have put calcar screws in that varus position.
Yeah, I think if you have approximation, stability, there is some amount of varus you can accept with a good calcar fixation, stable construct, I would leave it alone. because there was in the olden time we used to have even impaction and heal, so that is not a big problem. But in a young patient, you try to restore as much as possible.
Exactly, agree.
Move to the next patient, 55-year-old lady, known osteoporosis, left shoulder injury, 4-part displaced proximal humeral fracture. Of course, this is the CT scan. So, what will be your method of treatment of choice, Anand?
55?
55, 55.
55, good greater tuberosity. Non-dominant arm. I would probably do a reverse at this point. Looks like it's a fracture dislocation to me.
Right.
The medial calcar is gone, so not a great candidate to fix. Big greater. I'm between a hemi and reverse, but I'm probably leaning towards a reverse.
Okay, Nandan?
I think I would go for see, first you should have everything in place for fixation and hemi, but probably a hemi option for this because the tuberosity fragments are good and it's a head split fracture.
Yeah. So in favor of hemi or reverse, which one, Anand? You said. How do you decide?
Probably reverse for me.
For reliability or predictability?
Yeah, predictability on tuberosity healing.
Okay.
If the tuberosity doesn't heal, it still will function okay. But we see a high success in tuberosity healing with reverse. And I think with the current polyethylene and design, you can get a long lifespan with the current reverse system.
Take your point. Shirish?
Yeah, I think, see, just by criteria of age, and I can see a good tuberosity there, I'm still confident that if I do a hemi for her, of course, with the platform system, it should give her at least 10, 12 years of good result.
Okay. Shall I take it like you would attempt osteosynthesis?
No, I wouldn't. This is straight away a replacement case for me.
Okay. So she had RSA done elsewhere. So that's the first set of X-ray.
Ceramic sphere or some type of,
That's the model I showed you. So this is the 2 months follow-up. The patient had some pain. She was sent for physiotherapy by the surgeon. And 4 months later, she showed up in my clinic in pain, cannot move the shoulder, and slightly weaker deltoid. But deltoid is working. So this is the current X-ray. So comments. Anand, you said long, predictable.
Well, like anything else, you have to, doing the surgery well is part of it, but this is a really lateralized system. When you want to get the greater tuberosities to heal, you probably don't want to lateralize as much.
Too much.
So the tuberosities haven't healed here, obviously. So you have no tuberosity. You have a very lateralized, overstuffed system. Looks like an onlay type of system. I didn't see your original picture, but yeah, that's things, to avoid dislocation, impingement, which you might have had here, tough dysfunction, deltoid dysfunction, poor wrap, infection. Those are the things I'm looking at.
Yes. Nandan? Comments? Nandan?
Yeah, the tuberosity healing is key.
Yes.
Is what it confirms, that you need to good tuberosities to get stable reverses. So I guess tuberosity healing is important.
So see, I think that what happens, if you do reverse in young and if it fails, you have to do something.
Yeah.
And it's a very complex situation to handle now. But if you do hemi in young, and if still something goes wrong, GT fly, still it's anatomical, it's a forgiving situation. You can still pull on for a few years, months. So I think if at all we do reverse, we have to be sure that it is correctly placed with the proper sizing.
I think that's a valid points, because the more younger patients you operate, you have to be more careful in getting the outcome. So here now we don't have any other option to even overstuff the shoulder, which is already lateralized. So these are the operative findings, dislocated for some time. So we just removed all the scar tissue. This is the metal liner and the poly head. So not much changes could be done with the poly. So I just checked with the largest spacer available and put it up with the posterior cuff repair. I couldn't see the tuberosity, but I was able to see the posterior cuff. So I just tagged to the prosthetic, looked around it to have some stability there. So that is the stability the patient has. So didn't want to proceed further. Happy with that. So that's the revision of the dislocated reverse done for fracture. So that is her follow-up at 6 months. Note, she doesn't have good external rotation, which is expected, but she has a reasonably good internal rotation and forward elevation, and she's maintaining the result so far. But as you see the X-ray, there is no GT now. So, so tuberosity repair is the key. This is my technique. This I have done for even cemented prosthesis like debut prosthesis, reattach front to back, as Anand said, with medialized shoulder. It will heal very well, provide stability, reduce dead space, and restore power. So this is my experience of treating complex proximal humeral fracture at Mayotte International Hospital, although it is published by the current shoulder team. But what you need to see is that all patients had both GT and LT repair, and there were no tuberosity complications. Now, the last case, we are on time, 61-year-old, right-handed, diabetic, hypertension, osteoporosis, post-renal transplant, on dialysis, wheelchair user, known osteoporosis. Enough, Anand?
Stop.
Stop. 61-year-old lady, what will you do? Quick, because we have only 2 more minutes.
Non-op.
Shirish?
No, I see in axillary view, I think its head is extruded out. So
Yes.
Goes it out?
we need to do something. It's a fracture dislocation for me. So she's 61. So probably I will try to go and fix with a plate. We'll put her on some parathormone injectables, but I'll have a backup of hemi on table if required.
Okay. Anand? Nandan?
Yeah, I think CT is needed for this, Ram. I can't comment on that, but I think if the head is not dislocated posterior and anteriorly, you can still go with non-op, and if it fails, you're probably looking at a replacement.
Well, as Anand said, I was counseling the patient, but off the way through counseling, patient said, I don't want anything done. Not even CT. So I didn't bother.
Especially for fistula. If the fistula is in the right arm, it's a dangerous.
I said, okay, you can wait and see, because I was thinking, like, what is the point of fixing? Wait and see. If it is not done, then we will take the risk and do a reverse shoulder at a later stage. Like that, my thing worked. So 3 months later, she turned to my clinic.
Wow.
So my another key message is this: fracture can heal without surgery, because we are talking about all the high-tech technical details. Don't take the message that you have to go and fix every case, because the first case, as we were thinking, is the GT problem, but it could be better if the GT is managed. The rest of the fracture could heal conservative, but this is something impressive. You leave it like that in a sling. This patient has healed, reasonable outcome, not 100%, but the patient has no problem in day-to-day life. So to summarize, we are on time, with just about 30 minutes. Displaced 3 and 4 part fracture. Fracture reduction should be gentle, indirect, and use plenty of sutures. The second, GT and cuff interface sutures are the key in fracture surgery, more the merrier. Mind your plate profile, height and location if you're using locking plate, and screw trajectory as well, whether it is locking or variable angle. Restore the colca, screw fixation, graft if needed. And whatever you do fracture fixation, you do conservative treatment, you do hemi, you do reverse. Still, tuberosity repair is the key to success in arthroplasty. And if you want to, if the audience listening in India, if you want to learn more about, we run a course in July 27-28 in Chennai about complex trauma arthroplasty of the shoulder, elbow, wrist, hand, with a prominent international and expert national faculty, with a hands-on workshop for the shoulder trauma. You're most welcome. Thank you very much. Thank you, Vani and Mandeep. Any questions we will take up for the next 4 minutes.
As we wind down, Nick, do you want to, Poonam, can you just give him access? This is Dr. Verma we talked about.
Yeah. Ram sir, Yeah, Ram sir, I had a question was because in a young patient and the external rotation was not there. So would you do a transfer, muscle transfer?
No.
So when do you, even if the external rotation lag is there, or if the external rotation is not great, so if there is no muscle attachment, you wouldn't still do a muscle transfer along with the reverse?
Not in the fracture scenario. The fracture scenario, what I have seen, that was I was just quoting the result of the published paper. Basically, in a fracture scenario, we are not repairing the greater tuberosity attached to the supraspinatus. What you are tagging is only the external rotators, posterior cuff, which is infra and teres minor fragments. And we are also medializing the shoulder as a reverse mechanism. So the tuberosity side to side healing. There is no vertical healing. When there is vertical healing, more than 50% get resolved and you don't have GT healing. But when you medialize, there is a side to side GT, LT healing. Mostly they heal with the reverse shoulder. So I do not see a particular indication where you don't have external rotators power in an acute scenario.
So this particular case, which you did revision case.
For example, when you do for a revision scenario, in this particular scenario, we had a posterior cuff intact. The tuberosity resolved, but the cuff was intact, so I just tagged it. But I told her that if the external rotation is the problem, first we have to stabilize the shoulder, make it working. Then I said we will do a tendon transfer at a later stage, not at the same time.
So just another one question about your previous case. So in the scenario of the bone graft, I mean the GT getting resorbed off with an axillary nerve, so not a non-recovering axillary nerve, what would be an option? Because that is a situation where we can be.
The first patient.
Yeah.
See, if the axillary nerve is not recovering, and you can, I normally consult with my plastic colleagues, we just wait for 3 months. 3 months time, we go for axillary nerve exploration. And if it doesn't work out, then we have to go for axillary transfer for the axillary nerve. Okay. Have we started?
Yes, next up. Take it away.
Can you see the screen, guys?
We can. Always the best animations.
Well, first of all, thanks to the committee for putting this together. Welcome to everyone. Good morning in India. It's Friday night here in the United States, so we can't be responsible for what we say on this call, but we'll see if we can get through some great instability cases. Do we have Shreyash, Karthik, and Samir?
Yes, hi, Nick, and hello, everyone.
Yeah, we are out here.
Welcome. Great. So I have some disclosures. They're not directly related to the content of this talk, but you can see them on the American Academy's disclosure program. So let's jump right into some instability discussions. So the first case, 40-year-old female, progressive left shoulder instability. She's had a history of a first dislocation about 25 years ago, and since then has had multiple episodes of recurrent instability, including both dislocations and subluxations. She's able to self-reduce at this point. Originally, she had a reduction that required an ER visit, but now is self-reducing. Her goal is really to return to day-to-day activities. She works as a newscaster here in the US. She has young children, wants to be able to participate in their activities. Guys, anything else that you want to know on history, or what are your thoughts here just based on what she's telling you? Samir, let's start with you.
Yeah,
Or,
Nick, I think I would kind of rule out ligament laxity, in this situation.
So tell me about the fact that she was required reduction in the ER before and now is able to self-reduce. Is that concerning?
Yeah, it's just that the shoulders progressively becoming loose. So,
Right.
that is a factor. But if she dislocated 25 years ago, I would rule out multi-directional instability, stroke, generalized ligament laxity, really, in this situation.
The other thing I would be the other thing I would be concerned is bone loss, progressive bone loss. Probably she's losing more bone on the glenoid side, maybe. That's why the dislocations have become more often and more easier now.
Right. Samir, how do you look at the number of dislocations previously, and how does that affect your decision making?
Samir?
Do we have him here?
Nick, I can't find him. I texted him. Keep going.
Karthik?
Ask someone else.
Yeah, the number of dislocations, I do consider them in my decision making, because that gives me an idea about what the labral quality would be, although there is no literature suggesting a direct correlation between labral quality and the number of dislocations. But I do keep it in mind. I feel that the more number of dislocations, the labral quality might not be good. And I'm worried about bone loss. In more dislocations, there could be glenoid bone loss on the humeral side, which will definitely affect my decision making.
So here's her exam. She's healthy. She's fairly athletic in build, no tenderness, as you would expect when she's not having an instability episode. She has full range of motion, really no hyperlaxity on exam, at least in looking at alternate body parts. She does have fairly significant apprehension with the arm in a provocative position. So these are what her x-rays look like. Shreyash, what do you think?
At a quick glance, I don't think there's much of bone loss here. But definitely, I'd like to do a CT and an MR to get more information.
Yeah. So surprisingly pretty unremarkable, right? For a long history of instability, very little evidence of post-instability arthropathy. And more importantly, at least from radiographic standpoints, we're not seeing much evidence of a significant bone defect. And if you look at the axillary view, she still has a fairly sharp corner to the anterior inferior glenoid, which to me has been predictive of patients that have significant bone loss. So would everybody do both studies here, an MRI and a CT scan? Would you just want a CT scan? What's your workup? In the US, we would certainly get both. What's the availability of doing that in India?
Yeah, so an MR is a must, and definitely in modern day, with the concept of bipolar bone loss, I would definitely include a CT. Just from an economical side, I have a understanding with the imaging department that we just do a 3D CT and we don't do a plain CT. So, from a financial perspective, it does save some amount of money. But this is a must for me for instability assessment.
So here's what her MRI scan looks like. I'll give you guys a second to look at that. We'll go through it one more time. So Karthik, you were talking about the capsule and multi-directional instability. How do you really assess that? I mean, we've already talked about the Baton score. She's not hyperlax in general. Very unlikely that a patient in this age group would be hyperlax per se. Sorry, I lost it. Give me 1 second. So tell me about your assessment.
How many times has she dislocated? Sorry, I just missed that.
I mean, she's coming out weekly at this point, at least subluxing.
So, okay. So, and she's reducing it herself, right?
Correct.
Can she do it voluntarily? Did she can she do it in front of you?
She is not a voluntary dislocator. I would just say that.
So, what position does she dislocate every day? Like every time when she dislocates, in what position does she dislocate?
Well, at this point, she's dislocating mid ranges of motion, but we're pretty convinced she's coming anteriorly. Initially, when she had ER reductions, it was an anterior dislocation.
So whenever she lifts the arm and abduction external she dislocates. Is that right?
Correct. But now, as I said, it's mid ranges of instability. So and I think you see that on the MRI scan, right? Even though there's not a substantial Hill-Sachs lesion, there certainly
is a Hill-Sachs, yeah.
The anterior labrum is diminutive. But tell me about your thoughts on the capsule, right? That's the one area where I think we still struggle to make a true analysis of what's the capsular quality. Any tips that you have? What are you looking for other than hyperlaxity on general examination?
So on general, for me, shoulder-specific hyperlaxity, I look at external rotation in lying down position. So EOT we call it. So if the patient has external rotation more than 90 degree and definitely more external rotation than the other side, then we consider the shoulder as hyperlax. The other thing is the Gajjar sign and the sulcus sign. So all these three things, I don't usually look at Baton because Baton doesn't seem to correlate very well with shoulder-specific hyperlaxity. So hyper external rotation, Gajjar and sulcus gives me an idea about capsular hyperlaxity. And that's what I look at when I think about shoulder laxity. As far as the MRI goes, I'm not very good at reading the MRI for capsular quality. I still struggle with that. Even the Bankart lesion sometimes is very deceptive. To me, it looks like it's torn. My radiologist think it's not torn, and radiologist says it's not torn. But that sort of thing. So I rely heavily on CT scan and the clinical examination and the patient's history.
So
One
here's
more
what
thing, Nick.
CT.
One more thing I'd just like to add is, the sulcus, which is present even in external rotation. So that would kind of give me a clue of laxity, and obviously look at the axillary recess on a coronal image on an MR.
So
Hey,
here's
sorry,
what
guys,
her
I'm
CT.
here. We're leaving tomorrow morning at 6 a.m. on a flight, and my wife had me doing some stuff, and I lost track of time. I apologize.
Hi, Samir. Welcome.
How are you guys?
Welcome.
Hi, Samir.
So Samir, just to catch you up quickly, we've got a 40-year-old history of instability since the age of 25, initially required ER reductions, now having instability almost weekly, including mid-range instability, nighttime instability, finally is sick of it and wants to have something done. She has a fairly normal exam. She's not hyperlax. X-rays were normal. We looked at her MRI scan. It has a diminutive anterior labrum. And since you're here, we're going to let you comment on the CT scan.
Yeah, so you can see there's a flattened Hill-Sachs lesion that looks like it's pretty close to being off track, and she's got some glenoid bone loss there anteriorly as well. You can see on the axillary, and when you get to this coronal, you can see she's got some flattening of the anterior glenoid. It's probably less than 10%, but if you look at the combination of the glenoid and the Hill-Sachs, it's definitely going to be an off-track lesion right there. So for me, if she's athletic and she's active, for me, this is probably going to be a lateral J. But if she is someone who is not as active, just wants this to kind of go away and is, just a regular 40-year-old person who doesn't do a lot of CrossFit or something like that, or high-level exercise, we may be able to get away with the Bankart remplissage. But I have a discussion with her about one or the other.
So I let the cat out of the bag here, but I can't remember if it was Karthik or Shreyash who mentioned this. When you order these CT scans, you really want to make sure you get 3D reconstructions, because it just gives you so much of a better visual appreciation of the bone loss situation. You can see that the Hill-Sachs lesion is certainly much more than we appreciated on the axial views. And I calculated her bone loss at about 12%. And Samir, you talked about the on-track, off-track lesion. This is actually a near-track lesion. So it wasn't off-track by calculations, but it was near-track in that it was within 10% of an off-track lesion itself. So tell me, guys, what are you doing to calculate bone loss? Are you routinely calculating on-track or off-track? Or what is your decision-making process here? Let's start with you, Shreyash.
Yeah, so thankfully, a lot of these MR centers have started reporting on it. And obviously with these kind of end-phase view glenoid and axial humeral head, you get an idea. The final decision is intra-op, because we know that, even though imaging may show something, if we are operating a patient few months down the line, there could be progressive bone loss. So, on this view, it looks like, subcritical bone loss. And just in the interest of time, I would do a Bankart repair if there is a good labrum with a remplissage. If not, then I'll do a lateral J.
Samir?
Yeah, I agree with that statement.
So just to fill you in, she's 40. She wants to be recreationally active. She wants to do stuff with her kids. She's no longer in any type of competitive sports.
Yeah, and I think it's the MRI, but if there's I agree with Shreyash, if there's some level of a labrum there that we can kind of bring up and imbricate, I probably would go with the Bankart remplissage given her recreational activity level. But if there's not much of a labrum there, then I would definitely go with the lateral J.
So Samir and Shreyash, for both of you, the decision of doing lateral J, is it intraoperative? Is that what you're saying? You want to go in first with the idea of doing a Bankart?
No, so your point is quite good, Karthik. Basically, what I heard was that the labrum is not of great quality. So, my final decision, so I'll just do a quick scope, have a look around, because I don't do arthroscopic, I do an open lateral J. So, if so, then but I do all my instability work in beach chair. So, that's the kind of advantage for me. So that's how my thought process, particularly in this patient. Otherwise, it's more or less a pre-op decision.
Yeah, for me, it's a pre-op decision because I do my scopes in the lateral position, and then my lateral J is in the beach chair position. So I pretty much have to know preoperatively. Otherwise, I'm really going to have a tough time switching them over, and it's really kind of a painful process. So I usually kind of have a talk with them about it and kind of have a sense one way or the other beforehand with our imaging to go one or the other.
So, Nick, for me, I would actually discuss this with the patient. I would give her the options. Now, I would say if it was me, and if I was dislocating every week and I'm so apprehensive, I would probably opt for a bony augmentation procedure. So, probably for me, I will lean towards doing a Latarjet for her.
Yeah, for me, it's a pre-op decision. It's the exact discussion that you just mentioned, Karthik, which is what's the cost benefit ratio of open bone transfer versus arthroscopic in regards to recurrence versus complications, incision, those types of things. I think we all know our options for treatment here. We're debating between an arthroscopic stabilization with a remplissage versus a open bone loss procedure. Samir, what about an open procedure in this case?
Yeah, I think if I'm going to do an open procedure on her because of the bone loss, I would do the lateral J. I think the open.
So if you're going to make an incision, just put the bone back.
Yeah, exactly. Because but if this was like a big capsular tear, or someone who is hyperlax but without bone loss, I think an open Bankart in that situation can work really well. But for me, if there's bone loss, I'm either going to ignore it and do a arthroscopic, or I'm gonna address it with the bony procedure.
Yeah. So I picked this case because I think it's a really good discussion point about the fact that many of us are always talking about percentages, right? And 15% in this patient is very different than 15% in a rugby player in India or an American football player in the United States. And so although we use our measurements as a guideline, you've always got to take the patient situation into account in terms of making the right decision regarding the best procedure for the right patient. When we think about arthroscopic stabilization, it gets a lot of bad press in terms of the recurrence rates. I think that there still is a role, primarily if you're doing this in early stabilization, particularly with regards to 1, 2, or maybe 3 dislocations, avoidance of significant bone defects, capsular issues we talked about. Younger patients we know have higher risk, and sedentary patients are obviously going to do better. So based on our discussion with this patient and her goals of treatment, we recommended exactly as you did, an arthroscopic stabilization. I do this in a lateral position. Karthik, lateral or beach chair?
I do lateral for arthroscopy, yeah.
Samir, I think you said lateral, and Shreyash, you said beach chair.
Beach chair, yes.
Yeah. So I think the reality is you can do it in either position. For me, a lateral position is really helpful in that it just allows me access to the anterior and posterior aspects of the joint. It facilitates access to the inferior quadrant, and it really helps me deal with inferior pathology a little bit easier. So this is what her MRI looks like, her arthroscopic video looks like. Actually, not as bad a looking shoulder as I would have thought after 15 years of recurrent instability. We'll play that again. You can clearly see that there is a bone loss lesion. I think our estimate preoperatively of 15% is right on. There's clearly a labral tear that's extending beyond the 6 o'clock position. Capsular quality actually doesn't look pretty severe. And so I was happy to see this at the time that we did the arthroscopy. I think the technique for arthroscopic stabilization is really critical. You need to be comfortable with these accessory portals to allow you to access the posterior inferior and anterior inferior aspects of the glenohumeral joint. This is what they look like when you're positioning them on the skin in a lateral position. This is the mobilization of the glenoid. I like to look from the anterior superior portal, and I like to mobilize looking and viewing from the anterior superior while working from the anterior medial. You can see here that the bone loss is starting to look more significant, but we're going to mobilize the labrum all the way back around the posterior aspect. So we're going to try to shift the labrum as well as repair and perform a capsulorrhaphy. And then we're also going to address the Hill-Sachs lesion. But when you have these chronic instability cases, you should just be aware that the instability pathology will almost always extend beyond the 6 o'clock position. And so you really need to do a full 180-degree repair in order to achieve a successful outcome. The zone of injury, as we already talked about, generally occurs from anterior superior to posterior inferior. My repair construct in these situations is generally a minimum of 4 anchors, usually 5 to 6 anchors, especially with the smaller diameter anchors that are in use now. So you can see we established the 7 o'clock portal. We're placing the first anchor in the posterior inferior position. We actually placed 2 anchors posterior inferior and 4 anchors anterior superior. And I'm not going to show you the entirety of the technique, but a lot of the faculty on this call have technique videos that are available. My preference is these days to use these tensionable all suture anchors. They're very small, they're very strong. You avoid not tying in lower quadrants, which is somewhat easier and more reproducible. And we've shown that in the lab in terms of the outcome with biomechanical strengthening. And you can see that we're in the back taking just capsule. In the front, we're going to obviously take capsule and labrum to perform a capsulorrhaphy. So that's what it looks like when we get done with the labral repair. In terms of the remplissage indications, Samir, talk to me about your current indication. So we've already decided about an arthroscopic procedure. Are you using the engaging, non-engaging formula, or what's your thoughts now on performing a remplissage?
I use that, and then also if I have like a flattened Hill-Sachs and I feel like there's some anterior bone loss, I use that as an augment to try to tighten up the patient up further to limit the effect of their bone loss if they have it, if I'm trying to overcome it.
Yeah, I would just tell you that if you look at the data that's been available more recently, we just published a systematic review on this. Remplissage reduces recurrence rates, whether it's engaging or non-engaging. So my current algorithm is, if I'm doing an arthroscopic procedure, remplissage whenever there's a defect that's amenable to it. And I think we can get rid of this engaging, non-engaging concept completely. So it's look at the glenoid, decide if you're doing a bone loss procedure. If you're going arthroscopic, remplissage whenever possible. That would be the take-home message here.
Nick,
so this is how we...
Yeah, okay, go ahead. Yeah.
No, sorry, go ahead, Samir.
I'd love to hear the kind of the order that you're doing it, because there's the posterior side, there's the anterior side, then there's the Hill-Sachs with the remplissage. How do you what order do you do that in?
Yeah, so I used to do knot tying with the remplissage, which was really cumbersome because you'd have to go up into the space and find the sutures. You'd be using shavers, worried about transecting your sutures. Now I've gone to knotless. So I essentially do visualization. If you're lateral, you got to take the arm out of traction to remplissage. This allows the humeral head to displace anteriorly. And so as you're looking from anterior superior, you're going to see the remplissage. I use an all knotless construct. And basically what I do is I place the guide percutaneously at the inferior aspect of the lesion, and then a second pass superiorly at the superior aspect of the lesion. And then I essentially link my sutures. So I take the working stitch from the superior anchor, link it to the inferior anchor, and vice versa. And I do a provisional tensioning, but I don't tension it all the way down. Then I put the arm back into traction, start posterior inferior, work my way around the front. And the last thing I do is take the arm back out of traction and tension the remplissage. So it's a little bit of a hybrid going back and forth. Obviously, I think it's very difficult to tension the remplissage initially and still get the visualization you need on the glenoid. So I think to go back and forth really makes the most sense. And this is what it looks like when both the sutures are in. The postoperative protocol, I would say slower is better. I've gotten much, much more conservative with instability procedures. Stiffness is not generally an issue. It's much more common that you see recurrent instability. And so even 6 weeks in a sling is not a problem for me. Now, remember, the older they get, the more likely it is that they're going to deal with stiffness, the longer it takes for them to get their motion back. And when you add in a remplissage in, that's certainly true. So one of the discussions I have with them early on is it will take you a full year before you get maximal motion recovery, particularly in this 40-year-old patient versus the 17-year-old patient who will get their motion back really quickly. So arthroscopic, I think, is viable. The indications are key. The technique matters. Remplissage whenever possible are the take-home messages here. So case number 2, this is a 21-year-old female. She's had a history of recurrent right shoulder instability. She's had dislocations for several years. She did have an arthroscopic capsule labral repair done 3 years ago, and that failed about 8 to 12 months after her surgery. She started having subluxations and is now having recurrent dislocations, which are all self-reduced. She has full range of motion, positive apprehension, some tenderness over the biceps groove. O'Brien's test is positive as well. She does have mild hyperlaxity, so I would say her Baton score is 5 at this point. This is what her MRI scan looks like, and this is an arthrogram, just to be clear with you. This is what her lateral view looks like. What do you guys think about the MRI scan just in general? Samir?
So I think this is a classic case where she's hyperlax, she's failed, but it doesn't look like there's any bone loss here. So for me, this is the one. If they failed an arthroscopic surgery, either with me or with someone that I think is a good surgeon, then this is one where I'm going to think of open Bankart. If you look at that coronal view, you can see how light lax that capsule is and how inferiorly it kind of just is capacious, even medial to that glenoid. For me, that's one where you can really shift it over with an open Bankart and really get a nice tightening and get that inferior pouch to close up to really make her tight.
Yeah, so I would say amazingly, it's a pretty unremarkable MRI scan, right? Considering her history. The other thing that I do take note of, and I'm not sure how to measure this, I've tried to look at this going back retrospectively, but I think that there's a real discrepancy between the size of the glenoid and the size of the humeral head in some of these patients. And on the axillary view, you just get a sense that she's got a mismatch in size, even though she doesn't have a bony defect, that there may be some hypoplasia of the glenoid in general here. Is everyone going to get a CT on this case, or are you comfortable just what I've showed you on the MRI scan?
I'd definitely get a CT.
Karthik, CT? Samir, you talked about open capsular shift. CT still?
I'm already comfortable with this. Just, I mean, again, if I saw more of inferiorly and I thought there's any hint of a bone loss, I would get it. But if I can see the rim of the bone on the axial all the way up and down, then I won't bother getting the CT.
So we did get a CT. I just think it's helpful, particularly in the revision situation, to choose the right operation. Here's what it looks like. Be aware that the axial view will always underestimate the degree of bone loss, so make sure that you get that 3D CT scan. But here's what it looks like on the 3D. Shreyash, what do you think? Pretty unremarkable, huh?
Absolutely. Other than the maybe medium-sized hill sacks, nothing else. No glenoid bone loss.
Yeah. And what do you think about the anchor placement from the prior surgery? If you said, this guy just didn't know what he was doing, I'm going to do it again.
No, it looks good. I think he's done this.
Pretty darn good, right? I mean, you see 1, 2, 3, 4, 5, 6 anchor placements.
True.
Definitely all the way down to, close to 6 o'clock in the front and the back. So this is one where I think you got to be careful about saying that I'm just going to do the same thing again and expect a different result. So Samir, now you've got the full data. Still on board with the capsular shift?
Yeah, I think this is a classic one for that. I think she'll do well with it.
Yeah. What's your sense about when they have a component of posterior instability associated with the anterior component and your ability to tighten in that situation?
I still feel like you can get it. You really you got to make sure you get some of those stitches really inferior posterior and you cinch that up. And I've even put an anchor like at that 5 o'clock position anteriorly to get that 7 o'clock tissue more anterior and cinch up that posterior. I feel like you can get it when you get it open.
So Karthik, looking at the humeral side, I was, to be honest with you, very underwhelmed with the hip sacks as well. I'm looking at this and thinking, I don't think a bone procedure here is really going to make a difference for her. Here's what it looks like arthroscopically. So you can see she's definitely got a component of anterior instability because you can see that abrasion of the articular surface in the back of the humeral head, but no significant posterior lesion. And you can see that the sutures are in place. There's really no failure of the labral repair. I would suggest that there's maybe not even a significant labral component of her problem at this point. The biceps is located. Rotator cuff looks good. Karthik, what are you going to do with this one?
No, sir, Nick, sorry, I think I was muted. So when did she dislocate after her first surgery? And how did she dislocate it? And how did she dislocate? What was the...
No trauma.
And the first initial event was traumatic? The whole...
Initially was traumatic.
Okay. No, I really had doubts looking at her MRI and CT scan. Everything looks pristine. The technique was so good. And I'm starting to doubt about her muscle patterning, if there is any problem with her scapular muscles or if she's, some sort of an MDI or instability related to muscle patterning going on there. The arthroscopy view
what
also...
I would tell you, she doesn't have a significant component of scapular dyskinesia, and she really does not have a voluntary component of instability, at least that I could identify.
Okay. So I was trained in open Bankart repair, but I've actually given up open Bankart. I try to do Lataje if I open it up, or I just right now I think that I can achieve what I can achieve with arthroscopy, what I can achieve with open as well. So open Bankart is not in my armamentarium now. The arthroscopy picture looks quite good. So what did you do,
Yeah.
Nick?
What do you think about Latarjet in the setting of no bone loss? I worry about that because of the bone resorption that we see with Latarjet and the fact that I'm not sure that just making the glenoid bigger is really going to solve the problem in this situation.
I agree. Yeah.
I have some experience of doing Latarjet in no bone loss patients. They do quite well, and I have follow-up CT scans where there is some resorption of bone at the superior screw, but the inferior screw is quite good.
So I went to the Samir school of thought and I did an open capsular label shift. So typical deltopectoral approach. This is where being a shoulder surgeon is really important in terms of identifying the plane between the capsule and the subscap. That's probably the most difficult portion of the procedure, is to really to do a meticulous dissection in terms of identifying that plane, tagging the subscap separately from the capsule, and then a laterally based T-capsulorrhaphy, which will allow you to shift the capsule. I do understand what you're saying, Karthik, in terms of our abilities to now perform arthroscopic surgery, but my opinion is that there is still something fundamentally different than of doing a shift where you really are moving the insertion of the capsule versus just a crunching up of the capsule that we do arthroscopically. I don't have any science behind that, admittedly, but I think there's a fundamental difference. To Samir's point, I think when you have these kind of pseudo MDI patients, I wouldn't call her completely MDI because her primary instability pattern is anteriorly, but under anesthesia, she certainly has hyperlaxity in both directions. I think you just go beyond the 6 o'clock position with your capsule release so that you're really pulling up that entire inferior shelf of the capsule when you do your relief itself. So this is what it looks like when we tag the subscapularis. And in the interest of time, I'm just going to move forward. We've got 2 layers of tagging here. We're then going to tag the subscapularis. So there's our subscap at this point. We can now displace the humeral head posteriorly. And now we've got the capsule open. I've got a T-capsulorrhaphy with 1 limb of suture on each side. In this situation, I'll take a look at the labrum. If I think I need to augment the labrum, I'll put a couple sutures along the glenoid margin going down to the 6 o'clock position. But really, it's about shifting the capsule in a pants over vest configuration with the arm in a 30 degree position. And this is what it looks like when we get done with the instability evaluation under anesthesia once we're complete. And you can see she's nice and stable at this point. So the rehabilitation is extremely slow in this situation. I actually don't do anything for 6 weeks. I hold them in a sling and I start motion at 6 weeks, strengthening at about 12 weeks, and then really no contact or collision sports until at least a minimum of 6 to 8 months. So I think what we have to do is think about our armamentarium of what we have available to managing these patients. This includes arthroscopic repair, adding a remplissage, open labor repair, Latarjet, and then more significant either iliac crest or DTA type options. But remember the increasing severity of the operation, the increasing severity of the complications, and these are real. I mean, we're all shoulder surgeons here. We've all seen these complications, and they can be very, very difficult to deal with when you start to have screws and bone in place and something goes badly. And I'll show you that in a second. But I think the reality is that we've gotten away from this open capsular labral repair. But when you go back and remind yourself about the data, it's pretty darn good in terms of the recurrence rate of managing these patients. And I think it just has to do with the robustness of the ability to reconstruct the capsule label complex and the capsule itself. What doing Latarjet has taught me is when you do the Latarjet approach, what you really realize is how far medial the insertion of the capsule label complex goes onto the glenoid itself. And when we're doing an arthroscopic procedure, we're really putting stuff back on the rim, but we're not putting stuff back onto the glenoid margin. And so when I'm doing these, I'll often do a double row repair with a medial anchor through the labral insertion and then laterally based anchors along the margin to put the labrum back, and then a pants over vest configuration laterally on the humeral head as well. And it's hard to argue with the data if you go back and look at the outcomes for recurrence rates following open capsular label surgery, which are generally less than 5%. So my point in showing this procedure or this case is to know that there is, in my opinion, at least still a role for capsule label repair. In our experience, revision arthroscopic surgery for instability, about a 30% failure rate. These are my indications: failed arthroscopic repair without significant bone loss, contact athlete with a secondary ligamentous laxity, bony Bankart lesions, particularly those that are down low on the glenoid that can be hard to approach arthroscopically, and a Haga lesion. In these situations, I will still make an open incision. And even though I'm a heavily arthroscopic surgeon, there's no shame in doing that, because I think that not every arthroscopy needs a Latarjet, and not every instability case needs a revision procedure. This is our current algorithm in terms of how we manage this. 10% or less, we generally will add a remplissage if possible. Open Bankart is my go-to. Greater than 10% in a failed situation, I think you need to add back bone. But in a case like this, where there's really no bone loss, I think it's hard to make an argument that a bone reconstruction is necessary.
There is a lot of
we're going to skip case
queries.
3.
Lot of queries in the chat box about the DSA and the ASA sort of procedures. Have they become popular in the US now?
Say that again.
The DAS procedure, or the dynamic anti-destabilization with long head of biceps. What do you think about those sort of procedures, or adding the subscap, arthroscopic subscap augmentation? Do you, have they become popular in the US now?
The short answer is no. I don't have any direct experience with them.
Okay.
I think
Are you
that
seeing,
maybe in the setting of capsule labor repair, in a deficient capsule, it would make sense to add the biceps like we do with a rotator cuff, just to increase collagen. But I think in a case like this, where you've got capsule to work with, to me, it doesn't really have a role in my practice currently.
Yeah.
Any
Josh
experience
Stein
from the panel on those?
Josh Steins presented a series about it. I looked at it and thought about it about 8 or 10 years ago. I just really couldn't get to doing it. For me, the same algorithm you have, Nick, is what I use. And the open Bankart for me, initially for me, was like, hey, I don't want to violate the subscap in someone who might need to come back later for something. But, and especially in a young person, they heal and they heal well. And so when we can go back, if we ever need to do an anatomic replacement, you can do a osteotomy and not have to worry about that. So there's ways around that. So I've gotten less worried about, violating the subscap in that situation. And I really do think you can get such an amazing shift of that inferior tissue and just bring it up. And I even though I thought I could do it arthroscopically, I can do a much better job open in those patients who are super lax.
And Samir, you bring up a good point, which is meticulous management of the subscapularis during the dissection. And in my hands, it's a double row repair. So I incorporate my capsular anchors as the medial row in the subscap. I do a subscap tenotomy, so I do a lateral row in a side-to-side fashion. And it's pretty impressive what a good quality subscap you can repair you can get in those situations. So let's go quickly through case 4 as we're coming to the end of our time. 32-year-old male had an initial dislocation while snowboarding, reduced in the ED, recurrent subluxations, had an arthroscopic stabilization twice, and has had recurrent instability after each of those indications. Here's what his x-rays look like. We'll skip past this unless anybody has a comment about anything that is significantly worrisome on these x-rays. I would assume that everyone would go through the same workup that we just talked about with both MRI and CT scan. Anyone concerned about anything else they're seeing on x-ray?
Yeah, the axillary anterior rim, you don't see it, but on the AP, you can actually see it pretty well. It's surprising.
So here's what his MRI scan looks like. You can see obviously changes in the glenoid related to anchor fixation. Anterior labrum looks a little bit crappy, but not unexpected for revision surgery. Surprisingly, not a huge pouch low either. This is what the CT scan looks like in both planes. So to me, failed arthroscopic stabilization twice, at least a subcritical bone loss lesion. This is a Latarjet every day of the week and twice on Sundays. Anybody have any different recommendations? Shreyash, what are you going to do here?
I agree with you. This is a critical bone loss, not even subcritical. So I would do a Latarjet.
Latarjet?
Yes, absolutely.
Okay. So moderate Dandan patient, clear bone loss, failed arthroscopic stabilization. Latarjet, this is what it looks like when we got done. Samir, thoughts on the procedure and the post-op x-rays?
I'm still seeing the pre-op stuff here. But I agree.
Oh, is it not advancing?
Yeah, there we go. Yeah, I'm seeing the 3D.
Can you see post-op x-rays now?
Not yet, Nick. Not yet.
How about now?
I saw it briefly.
Still stuck? Let me,
Seeing it, yeah.
I'm going to share again.
Yeah, I can see, small, but I can see it.
So while we're doing
Can you
that,
speak?
just wanted to know from you guys in the US. So you still do, most of you still do a Latarjet and not ICBG or DTA or something as a primary bony procedure?
Yeah, I'm Latarjet for, less than 20%. If it's more than that, I'm going to go DTA.
Okay. That's
Yeah,
good.
so I'm the same way. If it's an instability problem, I'll do a Latarjet. If I think that it's starting to encroach on an articular problem, I'll do a DTA. So can you guys see at this point?
Yes.
Yeah.
Okay. So this is his post-op X-ray. Samir, what do you think?
So on the X-ray, it looks like the coracoid is just a little bit off there. It's kind of small on my screen, but it does look like it's a little off. But otherwise, position-wise, it looks great.
Yeah, so I have a hard time reading these. I always feel like there's a little bit lucency there, no matter how high you tighten them down. I think in retrospect, you could be right that maybe it's not as snug against the glenoid as we should. But I thought that the position of the graft looked pretty good, and it's
Perfect,
it's an autograft, and so okay, we take it how it lands. He came back at 4 months, having nighttime subluxations, and this is what it looks like now.
Yeah, they're starting to pull off there a little bit. A little further, and the screws are starting to back out a little bit there. So that could be, and then it looks like on the AP, one of the screws might actually be broken on the sagittal there.
Yeah, so we've got at least bent, if not broken screws.
Yeah.
We've got obviously a non-union in that situation.
Yeah.
So Karthik, now what do we do? As I talked about, Latarjet sounds great until you have this problem.
No, so what is he doing? At 4 months, why is he having this? What's the, is
he claims that he just started having instability, that he denies any specific injury or trauma. Take that for what it's worth.
So, yeah, so, in a well-done Latarjet, I expect this to have been done perfectly, and this is not expected at 4 months unless, something, he's being too naughty. So, so the thing is, at this point, I would actually counsel him that this looks like it's not good news. So he has to probably wait for some more time. Even a strong fibrous union at that area with some time can actually, we can probably buy some time there. But if we are thinking about revision, then revising a Latarjet, we have to be very careful. That's my thing. Because the anatomy is distorted, the brachial plexus not in the place where it should be, then obviously the only option we have got is ICBG or some sort of allograft for you. But this is a patient whom I'll be a little wary about.
Yeah, so I got a CT scan, and like you, the easiest thing to do is to blame the patient in this situation. Like, what are you doing that is causing this? But, Latarjet is a finicky operation, and the bone resorption is real. We can't always predict it or understand it. Samir, this is what it looks like on a CT scan. So clearly it's failed at this point, right? We've got screws almost hanging in the breeze. As you said, we've got one bent screw, one broken screw, not a lot of bone left. Are you going to wait on this, or you think I got to do something about this because this is not going to go well?
Clinically, if he has examination, he's got some apprehension. I think we're going to do something with this thing now. I don't think it's going to be salvageable. Every time I've seen one of these, I'm like, well, maybe we can salve it. It's like a big prune. It's a big nothing burger that you can't really do anything with. So this is the one for me. It's going to be a distal tibial allograft, ready to go. And so I will probably wait till I get the allograft and then be ready to go with him on that one.
Instability.
Yeah, so Karthik already mentioned this, but this is one that keeps you up for at least a week before the procedure, because the dissection is going to be a pain in the ass. The hardware removal is going to be a pain in the ass. You can't find the neurovascular structures, so you're really just trying to get to bone and staying on it. You mentioned DTA. Karthik and Shreyash, would you use that? Do you have it available in India? What would you use in India in this situation?
No, I would use a iliac crest autograft, and it'll be an open procedure for me.
Yeah. Karthik?
Yeah, the same. Yeah, iliac crest.
Yeah.
We don't have access to distal tibial allograft anymore. So.
What about
so Samir? I thought
on this one.
Yeah, that's certainly an option. I was just worried that I wouldn't get enough bone. DTA, I definitely. I definitely considered. The only thing I was worried about is if I really couldn't identify a traumatic lesion, is there some subcritical infection here that may be at play causing the massive bone resorption? And so that made me a little bit nervous about putting a DTA in. Would anybody scope this in advance and do biopsies and the whole 9 yards? Obviously, the lab tests are not really going to help us very much.
Not really. I don't.
Signs of infection or the clinical signs of infection, patient had any
Not
discharge?
overtly, other than the bone deficiency and the resorption, not efficiently.
Nikhil,
Yes.
Nikhil, this is Mandeep. Do you think we can wrap it up in next 1 minute?
Yes.
I think we're 7 minutes over.
Perfect. So some of the options are either, there have been descriptions of going back arthroscopically, revising a failed Latarjet, Hibinet procedure with an iliac crest bone graft, allograft, as we already talked about. We've used allograft in the United States with very good recovery. There are also some pre-shaped cortical allografts that are available. I was worried in this case about the fourth procedure, using donor bone versus autograft bone and potentially for an infection. And so I would just remind you that the iliac crest is a really good source of tricortical bone. You can deal with almost any size defect that you need to deal with. You take a tricortical graft, you can shape it to the size, and this is what he looks like. Unfortunately, he healed that uneventfully and is now about 18 months after his procedure without difficulty. So
Thank God for that.
questions?
I said surgeon's relief. He's healed.
Yes, exactly.
On those types of cases, I use nerve monitoring just because, I just don't know where the nerves are going to be. So for me, I'll monitor the musculocutaneous and axillary nerves throughout the case just to, keep myself, comfortable that I know when I'm working, I can be knowing that I'm not doing damage to a nerve.
Yeah, not a bad idea, Samir. The problem for me is it goes off so oftenly or so commonly that you're just like, now what do I do? It can almost be paralysis because you're just constantly dinging the nerves in terms of putting your retractors in and out. So it's obviously one where I think you just start laterally and stay lateral and get to bone as soon as you can. But we'll wrap it up there based on the time frame. Thanks, everyone.
Great cases. Thanks, Nick, Samir, Karthik. Great.
Nick, thanks so much. Great cases.
Yep.
Right, we're ready to switch over here.
Hello, good morning and good evening to you. Okay, nice. I'm Sujit. I'm from Cochin. Am I audible?
Yes, you're audible.
It's
You're
breaking
audible.
up a little bit.
All right. Is it okay? Is it okay now? Better?
Still breaking up a little bit.
Just a second. Okay. I'll
The visuals are fine. It's just your audio.
hope I'm okay. Can I start?
Yeah, this looks better.
All right, all right. So that's our panel. Dr. Hafiz Kazim from California, Dr. Ayyappan Nair, Dr. Jintan Desai, and Dr. Giri from Chennai. All right. So we'll start off with the case. We are slightly off our time. So that's a 63-year-old female, a homemaker, fall at home a year back. She had pain and weakness of the right shoulder, treated conservatively. There was a steroid injection given at a local hospital 6 months back, which gave her temporary relief, and then the pain came back. And she had severe dysfunction of the shoulder. The last 3 months, it was affecting her quality of life a lot. That were the examination findings. So there was a drop arm, which is positive, an MT can of 2/5. The infraspinatus is about 3 plus, and the subscap was slightly weak as well, but she could internally rotate. Those are the MRI images. Dr. Hafiz, your comments?
Can you play the coronal again, please?
Yeah.
Yeah, so I mean, it looks like so she's got a combined anterior superior tear. The subscapularis looks fairly repairable, probably an upper half. The supraspinatus looks large to massive, but repairable in my opinion. And then looking
It's
at
a Pata 3 as well.
Yeah, looking at the sagittals. I mean, a fair amount of atrophy. I mean, she has a little bit of minor infra atrophy. Sometimes you find that incidentally. It doesn't necessarily mean it's irreparable. So for me, at first glance, it looks like a repairable cuff, plus or minus some type of augmentation.
Okay, Dr. Ivan.
So this shows a grade 2 retraction, and subscap is definitely it is repairable subscap, and at least around 50% patty infiltration and atrophy is seen. So here definitely looks repairable, but definitely I would add on to a biceps. I do a biceps SCR if I'm having any kind of difficulty at all. It should come on easily for me. If not coming on easy, then biceps SCR with a subscap repair.
Yeah, you're right. The Guthiliar is only grade 2.
Yeah.
The Guthiliar is only grade 2, but then the occupancy is around 40-45% now. And infraspinatus has some fatty infiltration. Yeah. So conserve, repair, conserve is out of the question. Repair or repair subscap and SCR. Dr. Ayyappan, you're a good fan of SCR, I know. Or a tendon transfer or a reverse shoulder. So I think we are going for the repair, aren't we? Shall I show you the MRI, arthroscopy diagnostic? That's what we saw inside. Yeah, the subscap is very much coming on to the footprint. Yeah. And that's the superior cuff. There is an inferior lamella as well. That's a type of a lamellated tear. The superior lamella is weak. So now what? Again, a repair, Dr. Chintan?
Yes,
or would you do something more
it's,
to the repair?
Yeah, it looks fairly repairable. I think a double row repair should be sufficient to take care of it. If the biceps, as I saw, is fairly intact, so if I'm worried about my tissue quality, I guess I'd probably augment it with a biceps SCR since it's an autograft right there. I don't think we are burning any bridges by doing that if at all we need to.
Yeah, that's exactly what we did. We got a good double row repair of the supraspinatus and the infra. We passed through the two lamellae, and we added the biceps anterior cable for the anterior cable augmentation. Those are the two medial row anchors and the lateral row anchor. We added regenitin, that is a bovine patch. So can we have opinions on cuff augmentation from the opinion, Dr. Giri? On in a difficult scenario where you see a retraction, 1-year-old has gone through a steroid injection and the quality is not that good. So how do you think about augmenting a repair?
Yeah, looking at this case, even from the MRI, since there was some fatty atrophy, I would like to have some sort of backup plan while going, at least the biceps SCR, making sure the biceps is okay to start with. But since the patient is 63 and a female patient, I would look at her day-to-day activities as well. If it is a 63-year-old male, quite muscular, I would readily, take consent for a lower trap in case the quality is poor. But since she is a female, I would ask her activity level, particularly in India, if she is, not very keen on doing overhead activities fully, we might get away with biceps SCR. With the under partial repair.
Yeah, you talked about low trap transfer. The infraspinatus power was 3 plus. Without an external rotational accent, would you think about lower trap, Dr. Hafiz?
I mean, I think, lower trap, especially in the US, is actually expanding an indication. I mean, I still utilize it for people who have an ER lag. I would say that's not universally the case anymore, particularly in the US. I think more people are expanding those indications for essentially what we did for an SCR 6 years ago. So I think that is expanding. I would have actually done the exact same thing in this indication. when you talk about cuff augmentation, it might be an interesting conversation for you guys to let us know what you have available in India, but in the US, I mean, it's, patch mania, right? There's more cuffs than we can count in different types and products, different forms of patches. So, very often for us, how I indicate, which patch I'm going to use is very much on whether I think it's going to be a suture tendon interface failure or a bone tendon interface failure. So if I think this is going to be a healing problem, then I think some type of conductive implant like Regeniten or some other type of implant. But if it's a structural problem where it's going to be at the suture tendon interface, where I think it's weak tissue, then something like dermis augmentation, where you're going to utilize it as a structural washer effect. That's
rightly said. Rightly said.
We have synthetic options too here, BioBrace and all these other things that exist. So, that's what I would do. I mean,
with a good lateral tendon,
yeah. What are your graft augmentation options currently? Just out of curiosity, I mean, is it Regeniten your kind of your only choice, or what's commercially available?
Yeah, we have the BioBrace coming in.
BioBrace and Regeniten both.
Yeah, both are there. Yeah, and more companies are coming in with their patches.
Dermal allografts.
Yeah, of course, with us. Yeah, dermal allografts are there. We have the autograph options as well. We do the SCR as well. So this patient, we wanted to go all out because it was a patient I suggested and they picked it up. But then Regeniten, you have to think about augment. We have to think about tough quality. It's not reparable when the lateral tendon is not as strong. That is the patient after 6 months. A good husband had a cuff repair which has failed, and they're very happy that the Regeniten was done. It was one of the first cases we did 8 months back. So that's the post of MRI. See the Regeniten on the top or the cuff augment, which is supporting the repair well, and that gives good results. So that's very often post-op, and you can see the SAG image where the fossa is fully filled and infraspinatus has more muscle fibers in this, especially because we have pulled it forwards. Now the second patient, that's a 47-year-old male, finance consultant, play.
Hello.
Yeah, I think the connection got interrupted. In the meantime, can I ask the panel a question about assessing fatty atrophy on the sagittal sections? In the last case, if we see there was a retraction till the humeral head summit, or even slightly more like patty type 2 to 3. When it is a patty type 3 retraction, does the level at which you assess the fatty atrophy change? Do you go more medial in assessing the fatty atrophy rather than taking the point section at the coracoid? What is the view, Dr. Hassan?
I think you're exactly right. So I think very often MRIs, even the ones we get here, don't go medial enough. So I think it's very hard to just make a call on fatty infiltration based on a few sagittal cuts, and I think they're MRI dependent. So I think it's just one sign of reparability is the kind of how I take it into account. So I think if it's obvious and the entire thing is dying, then sure. But I think you're right. Very often we don't go medial enough to get an actual assessment, especially for large tears, because it's retracted. The cable, you very often see that dot, which is the cable, and basically the cuff cord, which you have to pull over. So
the level at which you assess should be at the level where the scapular spine meets the scapular body. So very often when outside MRI is done in centers, it may not go up to that level. So I always say go at least 3 centimeters medial to the glenoid face, which will usually include that area. Shall we go on to the next case?
Yeah. Sure.
Yeah, 47-year-old male, finance consultant, badminton player by recreation, fall at home, right shoulder dislocated, and close reduction was done in local hospital 30 days back. That was the MT can. So I think the diagnosis is out now. Those are the X-rays. No significant bone loss. Would you like to comment, Dr. Ayyappan?
It looks pretty fine because the AHI seems to be maintained. There's not much reduction in the AHI at all. And looks like possibly, considering the history, looks like a cuff tear with dislocation. Yep.
Okay. So would you look at this Sorsal sign, or how important is it in your practice when the undersurface of acromion is showing a sclerosis?
Definitely, because it definitely shows signs of impingement, which is pre-existing. But yeah, it does not change my treatment protocol because it looks like the AHI is still maintained.
So that's the MRI.
Yeah.
Yeah, Dr. Chintan?
Uh, I think that's a great point you made, that whenever there is a dislocation and then we reduce it, it's important to get an MRI, because often these cuff tears, if they go unnoticed and miss, then the patients land up in a problem with unable to abduct their arm. So an MRI at this stage was a great idea to get it checked.
When would you get the MRI done? Is it day one, or would you wait for the cuff to recover?
I would generally do it post the patient's pain subsides. So generally about a week or two with some pain medications. If they are pain-free post the reduction, that's a good time to. The earlier done, the better is what I feel.
Okay. So this patient came to us about 30 days later, and the MT scan was positive. So it was straightforward. We did the MRI, and we see a supraspinatus detachment, and upper subscap also was doubtful. That's what we saw on the arthroscopy. And you can see that the anterior cable is broken, and the right shoulder, and that's the supraspinatus, and you can see the long of the biceps there. So options: conserve, repair the cuff. The question is about cuff with banker. So would you repair both or repair the cuff alone? The patient is 47.
Okay. I'll take the question.
Yeah, please.
Yeah. So when we had a series of patients like this. So when we actually looked at the literature, so it is always safer to do the labrum plus the cuff. And the downside to this is, the older the patient is, the more chance of stiffness when you do the labrum plus the cuff. So when you look at the last time we looked at the literature, it was like maybe like if you don't repair in the older patient, chance of recurrence is much lesser. But so the older the patient, the dictum is the older the patient gets. So just a cuff repair should be fine. But a younger patient like this one should undergo both the labrum plus the cuff.
What is the order of repair? The cuff first or the labrum first? Dr. Hafiz? Yeah. Dr. Ivan, go on, please.
Yeah, the labrum, because definitely inside, okay, definitely the center of the head, the labrum first and then the cuff.
Okay. So that's what we did. So that was a labral tear elevation. We did a repair. It wasn't a large tear, but then the dictum is, if the labrum is unrepaired in a patient who's trying to play badminton again, the labral tear can lead to a recurrent cuff tear. So you have to think about repairing the labrum as well, along with the cuff. That's the message I want to give here. So that's the post-op, and the patient after 6 weeks, good function, and the MRI at 6 months, and he's back to his badminton. This was done about a couple of years back. That's the.
So if I can ask, so you mentioned doing it, like for me, I would not have fixed the labrum. I would have just done the cuff, because in my experience, these people get stiff, and I agree with your comment of saying, as they get older, I mean, the question is what's old and what's not. I mean, so I think, if they were 18, yeah, sure, I would have done this. But I think in my experience, when you have cuff tears that are particularly small to medium cuff tears in the setting of instability, they always get a little bit stiff. So I'm a little bit hesitant to fix labrums in them. And I would also mention timing, because very often these people will come in. I definitely try not to fix this immediately within the first 30 days, because in my experience, when you fix those cuff tears right away, there's so much bleeding, like there's a lot of hematoma, and those get stiff right away. So these are actually one of the few cuff tears that I wait a little bit for the inflammatory phase to settle down before I fix the cuff. Because
at 47, that's a good point. Yeah, that's a good point. How young you consider yourself. At 65, I would have left the labrum alone, but then he's younger than me, he's 47, and I play badminton. I feel labral instability, which is unaddressed, can cause a cuff tear. Again, a matter of debate. Can we have the other panelists opine on this? Dr. Sintan?
Sir, I agree with you absolutely. If I am going in, if I see a labrum tear, I would rather fix it than leave it alone.
Okay. Dr. Samir, are you there? Dr. Nick?
Yeah, I'm here. I agree with Hafiz. Like, I was actually looking at this 47 for me. Unless the patient's complaining after a few months of still having instability, there's no way I would fix the labrum. I would just leave it be, let it scar, and just fix the cuff and treat them as a cuff. And they usually stiffen up and don't get unstable, for me at least.
All right. So shall we go ahead? The next case, a 53-year-old man, left shoulder weakness for 2 years, advised rotator cuff repair. He chose to get him massaged in a traditional center, and that's how he comes to us. That's almost Apache 2 to 3. There, the subscap stone. Dr. Giri, can you have your comments?
Yeah, it's a 53-year-old male with almost patty type 3 retraction, and even the fatty atrophy is quite significant. I would like to know his range of movements as
Full passive range of motion. Yeah.
Full passive range of motion.
Full passive range of motion. The drop arm is positive there, and internal rotation power is weak.
So assuming that the patient is quite active, I would go with the idea of lower trap transfer.
That's the arthroscopy, the diagnostic. So would you change your opinion now, Dr. Hafiz?
Sorry, what was his active forward elevation?
Active forward flexion is not there.
So
he can do only up to a 30. Passive is full. There's no stiffness. Not a diabetic. So that's infraspinatus. Infraspinatus is lying near the glenoid. We are not able to pull it forwards.
I agree with Gary. This is someone for me that I would consider a lower trap for at this age.
Okay. Any difference of opinion, Dr. Ayyappan?
No, sir. I think it's fine because a lower trap is the best answer here. Yep.
But then the fatty infiltration wasn't much for me. We'll go through the SAG image. It is not infiltrated. Yeah.
So I would do a maximum repair. Even a partial repair is good with me, along with the trap transfer, because that's basically because of the infraspinatus. And if the infraspinatus is especially weak, then definitely I would do a lower trap plus a partial repair at least, and with a proper mobilization, a muscle slide, I would add.
Good. I had something else in my mind. So this is what we did for the patient, muscle advancement. The Rajesh Gupta technique, This is the 1981 technique, which has been popularized now the arthroscopically by Gupta. And that is a beautiful technique. We've had done few cases and the results are quite good. When the tendon is good, the muscle bulk is good. When it's just retracted, I try to release it and they come forwards by about 1.5 centimeters forward. So you get a good coverage. What is coming to the edge after release can be made to come over the footprint to do a double row repair. And we could manage. I'll show you the video. So that's the muscle advancement, the medial incision over the scapula, the medial bottom scapula, and you elevate with the corpus elevator, the infraspinatus and the supraspinatus. And that's what we got after the releases. There, it was coming over the footprint now after the release. So before doing that, we do the suprascapular nerve release to start off. And that's the anterior anchor and the posterior ones as well. And you can see it has come all the way over the footprint. So the opinion of the panel on this technique, please.
It's a great technique, but we've just started using it, learning from Ashish in the last academy we had from India. But I don't have experience in it, but I think it's a great technique. I think we should definitely try this, yes.
What is the experience from US, Dr. Hafiz, about advancements?
Yeah, I mean, I think it's great. I mean, we were talking about age, so I'll let it's from 1984 to give you an. I was born in 1988, so so I think there's some difference there. But I think it's a great way to do it arthroscopically. I mean, I heard about them, but I haven't had experience with it or
it is a good technique.
I think it's great to be able to do that arthroscopically. Yeah.
So points to ponder supraspinatus full thickness stairs are often difficult scenarios. So
Dr. Jose, one question from my end.
Please.
I would just like to ask you, like I met Ashish about Dr. Ashish Gupta about this, and he says pretty much any sort of retraction can be sorted out with his muscle slide. But my only question is about, do you change your rehab protocol in this sort of a scenario?
I know. I give an abduction. I give an abduction brace for 3 weeks so that it heals and settles down, and then we start mobilizing, just like a massive retracted. So that's one of the few scenarios where I give an abduction brace. So the points to ponder eventually cuff tear will lead to a retracted tear. That is another point I want to bring up. A supraspinatus tear isolated in a young patient, which is left alone, done conservative, it usually ends up in a massive tear and the patient tries to be active because they are compensating with the subscap and the infraspinatus that will eventually fall off.
I have a question here.
Quick question, Sujit?
Yeah.
Quick question.
Yes, please.
with reference to massive tears, you are the one who's doing all the three, so SCR, biceps SCR, and low trap, and now muscle advancement as well. So what algorithm do you have in mind when you see a patient with a massive cuff tear? How do you choose between the three?
Good question. So if you have a good muscle bulk, you have a good tendon, then I would prefer to do a muscle advancement and repair. If the muscle bulk is bad, if it is infiltrated more than Gothelier 3, especially the infraspinatus, I would try to go for a lower trap transfer. And there's a gray zone between supraspinate, SCR and lower trap. So if it's alone, the supra alone is weak and retracted and not reparable, I think about an SCR, either a biceps augmentation alone or a autographed facial ATA.
I agree, because it is very clear, because you need the anterior posterior force couples have to be intact for an SCR. And suppose the infraspinatus is not there, it is basically for a posterior superior tear. So then you add on the lower trap. So yeah, but the muscle slide covers everything.
Yeah.
Is there an age? Is there an age
Dr.
limit that you would consider a muscle advancement for? Is there, in your experience, is there an upper limit to what, regardless, just basically atrophy?
I've done up to 60, 65. I think 64 was my oldest patient till now. Usually for younger patients. Older, we try to think about reverses.
So you have reverse in your armamentarium as well when you think of massive cuff tear, even without significant arthritis.
Above 70 years, with a failed cuff, when the tendon is bad, I think about going to a reverse, which is a easier solution for the patient and more predictable for the surgeon as well. Dr. Samir, you were making a point there?
Yeah, I was just curious. So in terms of the rehab, you said immobilize for 3 weeks and then you start mobilizing. Is that active range of motion at that point, or are you just doing passive at that point? And when do you start active range of motion after this type of tear with the muscle slide?
Yeah, a good question. So 6 weeks, we don't give any active range of motion. Even in the abduction brace, we just give the elbow movements and wrist, slight forward flexion with support. But active movements are started only after 6 weeks, after the cuff has started to heal. And we start strengthening after 3 months.
Perfect, thank you.
And one more case, that's a 56-year-old female, rotator cuff repair done 18 months back at the center. The pain increased 6 months afterwards, and there was a drop arm positive, and the external rotation lag sign was positive. That's the X-rays. Comments, please. Dr. Giri?
Yeah, I would have an MRI to see the intactness of the tear, but probably the anchors are in position.
There you go. So metal anchors used there, titanium ones, but the cuff has come off and it's lying near the glenoid.
What was the age, sir?
She's 65.
55.
Sorry, 56.
56 and
yeah, less than 60.
The sagittal is
there.
Yeah, there is
the occupancy is less.
Yeah, occupancy
in
is
supra and infra.
Yeah. So straightforward. This is not a straightforward revision. We need some sort of augmentation, like we discussed before, since the muscle is also gone. Superior capsular reconstruction or lower trap transfer could
revision cuff is out of the question, isn't it, Dr. Hafiz? Any comments on that?
Yeah, I agree. I mean, I've really moved away from supracapsular reconstruction. I think, it's kind of, for better or worse, fallen out of favor in the last couple of years here in the US. If she was 65, I'd probably do a reverse, but I think at 55 or 56, I think probably looking towards a lower trap. I think the issue that would be real estate. I mean, my experience doing those things with previous metal anchors can be very difficult to get the right placement for your anchors. So I would do it, but I think she would just need to be counseled that she's getting a reverse eventually. We're just trying to buy her time.
That's a lower trap. We use the peroneus longus graft. We don't have the Achilles as easily available now. I think we have the Achilles which can be brought in. Yeah. So, Dr. Ayyappan, your thoughts on the onlay versus inlay of lower trap transfer? This is an inlay method we use with a adjustable loop.
So I definitely do the same. So I've done a few cases with the onlay. But I think the healing is much better. The fixation is much better, and mobilization can also be much faster within inlay. So we regularly do with a tightrope. You flip it from, normally I drill it from posterior to anterior. clipped it in the bicipital groove, and then tighten it up. So definitely I think inlay is much better. It is the same as like a dynamic anti-stabilization inlay. So the fixation of the grafts are much better inside, and mobilization faster. Yes.
Dr. Chintan, your thoughts on that?
Excellent presentation. Only my concern is about the predictability of her recovery in this situation. With a significant fatty infiltration atrophy, as well as that we saw on your second MRI post the first surgery, I would probably lean more towards going to a straightforward reverse because she's 56. She is not too far from a reverse at this point in time. I guess that would give her the best chance for a positive recovery in this case.
The subscap is good. Only the supra-infra are bad, infiltrated. Dr. Hafiz, would you have any other comments on this?
Yeah, no, I mean, I think the inlay concept, I would say that's very extremely rare. I don't know anyone doing that in the US. I mean, maybe there's a few people, but I think because we have access to the Achilles, it's pretty much universally onlay. So I think that's an interesting concept that we talk about. I mean, I think the idea of, doing a reverse in a 56-year-old, I don't think that's crazy. I think realistically, I mean, if we do a lower trap and you're adding Achilles and you're adding bulk allograft, the reverse is probably going to be more complicated in a few years. So I think it's a reasonable conversation to have, depending on expectations. But her risk of revision reverse is extraordinary if you did it now. So I think, for me, I would still probably try a lower trap in this case.
With respect
there was a
to
case
onlay,
which...
with respect to onlay versus inlay, what do you feel with respect to compensation for supraspinatus? There is a thought process that when you put it onlay and bring the anchor points more anterior, it compensates well for supraspinatus. Is that the same with inlay? Is that the same with
That's
inlay?
a very good point.
There is
that's a good point, Dr. Giri. I also shifted to the onlay method now. This is how I started. And now I'm doing more of onlay after seeing Basam, especially doing the onlay or forward. So I used two anchors on the front and one for repairing the infraspinatus. There's a case which, Dr. Giri, I think we are running short of time. There's a 48-year-old male. Can you please explain the case, Dr. Giri?
Yeah. This 48-year-old male now works with the Woods. Had an injury about 27 years back. The initial injury was 27 years back. He had some sort of injury to the shoulder with probably axillary nerve injury, for which sural nerve transfer was done. After that, he was fine with almost full range of motion, quite muscular guy. But he again had a rebound injury during cutting a wood last October, and he presented to us with the inability to lift the arm only after this recent injury. So those are his X-rays. When we look at his X-rays we could identify some vascular clips here and there, and there was a prominent anterior and posterior incision on the shoulder as well as on the calf region for the sural nerve harvest. But the medical records were not clear about the previous surgery. Yeah, the next slide, please, sir. So his examination we saw the scar, and there was a gross deltoid wasting, particularly anteriorly. We can see his bone. There was a gross wasting of the deltoid with the asymmetry, but the sensations were normal. There was no Ridgman badge sign, and the movements were quite less. His forward flexion was 70 degree, but had some sort of compensation from the trunk muscles. There was no abduction, barely 10 degrees. External rotation was about 30 degrees, but quite weak. But the internal rotation was good, and the Virk test was negative. So next slide. So this was his MRI. There was a patty grade 3 retraction, posterior subluxation with of the joint as well. And there was a gross deltoid wasting with fatty infiltration. Dr. Hafiz, what will be your opinion on this? How to go forward?
Yeah, I mean, this is a extremely tough problem. So just to recap, I missed it. So he had what nerve transfer?
Sural nerve transfer, probably. We are not having his past medical records, but the point to be noted is he was working fine after that. This was 27 years back. All his symptoms started only 7 months back after the recent injury.
But he had a sural nerve transfer to what? Sorry.
To axillary nerve.
To axillary nerve. Okay.
You mean You mean a cable graft was done? Okay, that's what it is.
Yeah,
Right?
yeah. He's
Okay.
a foreign national. We didn't have his medical records now. So
And does
we had
his
assumed.
deltoid work? Does his deltoid work now?
Yeah, from the examination, I didn't share the videos in this PowerPoint, but Bertolli test was positive. There was no deltoid extension lag. So some amount of deltoid function was there. We were not entirely sure about the complete function. And with significant muscle atrophy, we went ahead and did a nerve conduction study for the axillary nerve and EMG. So the EMG results where his middle deltoid is firing. Anterior and posterior deltoids are quite weak, but he's compensating using his triceps for the posterior deltoid. Anterior deltoid is weak, and the forward flexion is also because of the trunk compensation. The middle deltoid is firing. The axillary nerve is functioning according to the nerve conduction study.
Yeah, I mean, I think if you're convinced that you have enough deltoid function, I mean, a young reverse is not crazy in this situation. I mean, I think if the deltoids are not functioning and it truly has, a palsy and it's not working, either a reverse with a pec transfer, which I have not done, or a fusion. I think a fusion is not unreasonable if he's truly neurologic.
Yeah, let me summarize the problem statement here. So these are the MRI reports and the EMG. So let me summarize the problem statement here. So this patient is a 47-year-old, quite muscular guy, very active, has no forward flexion as of now. But his middle deltoid is firing as per the EMG reports. And on MRI, he has a cuff tear with significant fatty atrophy and massive retraction of the cuff as well. So now, how do you approach? Is it a straightforward rotator cuff repair? There are reports even by the MGH group telling that even in deltoid paralysis, patients do compensate with intact cuff alone. So we don't know if he was compensating with the cuff alone in the past or his deltoid was actually firing. And the second option is, will you have a backup of lower trap transfer considering the massive retraction of the rotator cuff? Will you add a pedicle pick at least for the forward flexion, or would you straight away go with the reverse?
Dr. Giri, sorry to interrupt. We've got 2 more minutes in interest of time. This is an interesting case, but if you could wrap up in 2 minutes, I'll really appreciate it.
Yeah, this just for discussion. The patient has just been admitted. We are about to operate the case, so we thought of discussing about the case to arrive at a decision. Can you, Dr. Sujit?
Peg major transfer is peg major transfer is a good option. Yes. For that, please keep us posted on the results. Can we have one more case before we go? We got a minute now.
No, we are out of time. Unfortunately, I know this is really interesting, but we are already 5 minutes above. But
yeah.
So I really want to thank everybody, my co-organizer, Vani, all the panelists and moderators, especially Dr. Ram, Dr. Jose, and Dr. Verma, all the panelists. I also want to thank OrthoTV for helping us organize and live telecast this, Dr. Neeraj, Dr. Sham, Ms. Poonam. And again, this was a very enticing session, and I want to thank all the participants as well as all the viewers who took time both at night in the US and in the morning in India to participate. And I want to thank everybody.
Thank you. Thank you. It was a wonderful session.
Thanks, everyone.
Thank you for organizing.
Good night and good morning. Have a good day.
Thank you. Bye.
You too.
Thank you, everyone.
Bye, everyone.
Bye.
Good night.
Take care, everybody.
Good night.
See you
All
soon.
right, Shreyash, thank you.
Thanks, everyone. Mandeep, Vani, Samir, Anand,
Bye,
and
everyone.
the
Thank
Indian
you so much.
contingent. Thanks a lot. See you
Take care,
sometime soon.
everybody.
Bye. Take care.
Bye.